Welcome back for the final chapter. That sounds so dramatic. The final video on the suicide assessment training, where we finish up the steps of the training and kind of what to do with the information that you've gathered. So we'll scroll through and get to, we just covered assessment questions in the last one, kind of what to ask, how to kind of flesh those things out. Again, it's difficult because you are in a role where there's a lot of clinical pressure, just in the sense that you might encounter things that are pretty heavy. It might be crisis situations. At the same time, you're not a clinician nor expected to be. So finding that balance of like how to be a support without taking on the role of a therapist, it's a tricky one. And again, this is just to empower you to kind of, if you ever put in this situation, you'll at least have the tools to be able to navigate it, hopefully with some confidence, and get the student to a place where they are safe. So after you've asked the questions, kind of gathered the information and had the risk inquiry, you're going to determine the risk level and kind of what intervention is needed. And so you're trying to match with intervention with the risk level that you've identified. So the assessment of risk, it's based off your clinical judgment. So again, just based on the information that you've gathered. It's important to continue to reassess as the process goes on, because you might be able to establish a sense of safety for the individual, but something might trigger them. They might get a phone call or a text or just get in their head and they're not able to follow through on the plan, or something might have changed that you make you go back to kind of reassess what you have learned and what you've gathered. I did put this disclaimer, and I've said this now a million times. You're not expected to be clinicians and do not hold the responsibility to provide the clinical assessment. If you find yourself in this situation, this is where you're just trying to get them to be safe enough that either a supervisor can come help support, or if their chair happens to be on site that day, whatever the additional outside support is, you're just trying to get the person to be in the safest place possible. So if we are looking at risk level assessment, there's 3 different risk levels that an individual might fall in. High is obviously the most intense and the calls for the most immediate action and the most intensive response. And so if you have done your risk and protective factors assessment and kind of fleshing that out, the risk factors that would be present for a high risk level would be if there is some untreated psychiatric diagnosis and the symptoms are severe, or if there is some sort of acute, so like really immediate precipitating event. So again, like a breakup with a boyfriend, a falling out with a family member, anything those things are so high that no protective factors are going to be relevant. And so no matter how supportive a family friend might be or how future focused they might be, there's such an intensity of either a psychiatric diagnosis or the event is just too great that safety cannot be established. If you're talking about the level of suicidality, there's potentially lethal suicide attempts. So someone had made an attempt and you'd either intervened or happened to not be successful. Or there's a strong rehearsal of the suicide plan, that would be considered high risk. So usually at that point, admission would be indicated. So they should go to a psychiatric hospital. So that would be often the one in town would be Pine Rest, is the one that's utilized a lot. What would end up happening is the insurance does play a part in where they can go. So if they have private insurance, often Pine Rest, calling them directly, would be the method, the route that you would go. However, you would want to consult with a supervisor and follow whatever protocols in place as far as the student development end. But typically, if risks are that high, you are going to want to look and explore what a possible inpatient setting could be. If the risk level is moderate, and so there are some risk factors identified, but there are protective factors that seem to kind of balance it out or help keep the individual future focused, it would probably place them in the moderate because they're expressing some intent to continue on with their life, and the negative thoughts or the forces are not higher than the protective factors. As far as the suicidality risk, there might be some ideation with a plan, but there's no intent to follow through, or there's enough future focused thinking or supports in place to kind of counteract that, or to monitor them until they can get to some sort of outpatient support. If you're a moderate risk level, admission might be necessary. Again, depending on how intense the risk factors are. But the route to usually go if they're in a moderate level is to develop what we call a crisis plan. So how are you going to get through the rest of the day or get through the rest of the night to get yourself to a safe point where you can either call your therapist, go home to your family, or kind of get the support and help that the long-term help and support you need. So it might be like, a crisis plan might be like, every hour I'm going to text this friend, or I am going to go spend the night at my parents' house, or I am going to attend class at this time. If I'm starting to feel overwhelmed with the thoughts again, I am going to call this person, or I'm going to do this. I'm going to give all the prescription medication in my room to my roommate. Again, you want to kind of be careful where you're putting the responsibility of helping the person get through the crisis, because you don't want to take too much on yourself or put it on somebody who might not be willing to support. That all kind of goes into when you're fleshing out who are the protective factors. They kind of get pulled into the crisis plan. Providing them with emergency or crisis numbers. I'll get to that in a future slide. There's 1-800 number to call and a texting number where you can get immediate support if someone is not available. A low risk level would be that there's some risk factors present. So maybe there was a acute precipitating event, but it's not impacting them at the point where they are unable to stop thinking about it, and there's really strong protective factors. So good supports, good plan in place, still thinking about the future, a lot of motivation to continue looking on. So that's kind of where like there's more ideation than actual intent. You can see that suicidality box says there's thoughts of death, but there's no plan, intent, or behavior to indicate that they are actively preparing to have an attempt. So usually that would be an outpatient referral. So third chair is considered outpatient. Whatever the kind of, again, hyper policy and protocol is around that. Obviously third chair is the on-site support. If it happens to be that they want to go somewhere else, they have that option as well. It's just focusing on anything to help reduce their symptoms and focus on coping skills that they already have and utilizing their support system and protective factors. It's always helpful too to give the crisis and emergency numbers just in case they need someone to talk to if no one's available, or if the risk factors start to increase. So hopefully that kind of makes sense a little bit. Again, people saying that I want to die or I want to kill myself doesn't always put you right at the high level. It could be low, but you need to kind of make sure you're looking at all of these different, how it kind of just flows out. So what to do if the person you're sitting with or who's come to you falls into each category. Obviously, a high risk level is the most acute and brings the most risk with it. Remaining calm, again, is the best thing that you can do in this situation, even if you are freaking out inside. Having, if you're a social worker and taken individuals and families, or if you're not, we refer to it as the island of calm. And so you are this oasis of calm for the person to kind of come to. And that's your role in the situation, is to keep the environment as calm and stable as possible. In order to kind of bring balance to a person who might be elevated at the time. If you do believe that this individual is a high risk for following through, you don't want to leave them alone. Obviously, that increases a risk. There is more likelihood they're going to do something if they are alone. If they happen to have the lethal means on them, obviously you need to keep yourself safe. But if there's a safe way to remove the lethal means, heaven forbid it be a gun, you need to keep yourself safe. Don't be a hero. But if it's pills, encouraging them to give them to you to hold on to. In the case that I talked about in the last video, with the individual who had the knife, I knew that he wasn't going to stab me, or if he tried, it would just bounce off me. I was able to talk with him and convince him to give it to me to keep him safe. Again, I am a professional clinician. I know how to do the de-escalation intervention. So you need to also remember to keep yourself safe in the situation. But if it's safe enough for you to remove the lethal means, that's something that could be a possibility in this. You want to connect with your supervisor ASAP as well, and they'll be able to help walk you through the next steps with inpatient care. Moderate, you identify the crisis plan. I did kind of talk about that on the last slide. So you really want to look for future focused thinking. And if they're unable to think about the future, then it might bump them to the high risk. Give them the crisis care phone numbers. And I think what's really important to note in this level is that you are not their long-term plan of support. And so you might be somebody who they really feel safe. You might be one of their protective factors. But in order for them to figure out how to navigate crises on their own in the future, you cannot be the person that they call nonstop. You cannot be the person who keeps them safe long-term. So trying to help them find their external supports is going to help them in the long term. If they're a low factor, remind them of their coping skills and positive factors, encourage engagement in outpatient care, and also provide the crisis numbers again. So what to do after, this is the documentation stage. So after all of this comes, you've figured out their intervention plan, you have kind of identified what is going to happen. In a clinical setting, you'd want to document this because it helps with liability. So if you really, not release them into the wild, but like left them physically and then they decided to actually follow through, documentation would show that you did everything in your power to keep them safe, and that was their choice and that was their self-determination. You don't necessarily have that liability, I don't think, at Kuyper, but documentation is good just because it's going to show if the situation arises again, it kind of gives a history of what happened. So you're just going to kind of want to take note somewhere what risk level and the rationale for why you put them at that, what the treatment plan was, what the follow-up plan is, and if there's any information about firearms. So those are the 5 steps in kind of a nutshell. I probably talked about them a little bit more than I anticipated to in this video, but you kind of got to flesh it out a little bit. So after the assessment, crisis situations can be very, very triggering for the assessor. There's the vicarious trauma and the secondhand trauma of hearing and experiencing what could be a possibly lethal or very emotionally charged situation. So always debrief with your supervisor and your peers, remembering confidentiality, but you want to make sure that you don't internalize everything. You want to be able to debrief and check in on your own well-being around it. So practicing self-care, resist the urge to internalize. That is so easy to do because it can be a very emotionally charged situation. But you want to practice whatever kind of self-care is healthy for you. So journaling, praying, running, playing piano. You want to just get it so it's not sticking with you. Remember your role in follow-up care. I mentioned this in the last slide. You are not the professional provider, so make sure you keep appropriate yet supportive and loving boundaries. With some mental health diagnoses, individuals do not have healthy boundaries, and they might push to get from you what they want. That's not healthy for you, nor is it healthy for the individual in the long term. So always making sure that it's clear what your role is in the aftercare and your supports. If you did agree to any steps during the assessment, so whether it being like maybe a phone call or a check-in or giving them the referral information to third chair or the referral or the phone numbers for the crisis lines, make sure that you follow up on whatever you've agreed to do, because that does build a sense of connectedness and trust, which is really important. Connectedness is one of the biggest prevention factors in suicide treatment. Is when an individual feels connected, the likelihood of them following through is going to be lower. So following through in anything you have said you'll do will help build that connectedness. There's many resources. I mentioned the crisis line and the texting line. They are listed here. Network 180 is the local one for individuals who have no insurance if they need an assessment. But these are good resources as well. I'm always free and happy to answer any questions. This is my clinical background and I love to talk about it. So hopefully this was